let's emphasize on how I manage the thrombus. I don't have any financial relationships to disclose. For the case one, 48 years gentleman who is a heavy smoker, 20 packs years, presented with the inferior wall STEMI, and ECG showed the ST elevation in 2-3 AVF with reciprocal ST depression in the wall AVN V1 to V5. And echocardiography shows the inferior segments, basal and mid-septal wall hypokinesia with reduced LV systolic function with the EF of 42%. Here we notice the regional wall motion abnormalities is not only in the basal wall, but also in the septal wall. So this is his left coronary angiogram. Here we can see some thrombus in the proximal LAD, followed by the myocardial bridge in both LAO and RAO cranial view. Again. This is his right coronary angiogram. Here we can see the high thrombus burden in the right coronary artery. So in this case, we have some problems here, like both the LAD and RCA are involved, and high thrombus burden in the right coronary artery, and also the severe myocardial breaching at the mid-LAD. So in this situation, we defer the PCI as the TB flow is quite okay, and we give him the intracoronary GPI injection followed by the infusion for 12 hours and as he suffering for a week. We do the recheck NU after a week later, and here we can see the complete vanish of the clot in the LAD, but still the myocardial breaching here. And for the right coronary artery, we can see that here there's a small indentation. There's some minimal luminal diameter stenosis in the proximal RCA with the good TB3 flow. So the patient is stable, no chest pain and resolution of ST. So we decided to observe and keep on the optimal medical management in this case. For the myocardial breaching, we give him a beta blockers to control the heart rate, and we just keep the follow-up for him. Okay, the next case is the 45 years gentleman who is also a smoker for 10 pack years, presented with the anterior wall STEMI. ECG shows the ST elevation V1 to V5. Echo shows the LV apex and septal wall hypokinesia with the preserved LV systolic function. Here we can see the total occlusion starting from the ostial LAD. Right coronary artery is quite normal and a good TB flow. In this case, we proceed the PCI, primary PCI with the Schönbrunn wire with the Mogu microcatheter support, as there is a total occlusion in the ostial LAD. Here we can see the high thrombus and after wire crossing. Then we made the balloon dilation with the pre-dilation with the Sapphire 2 Pro 2 or 12 millimeter. And then we deploy the DES 3.5 to 36 millimeter. Here is the final result. So his condition is stable and he can discharge without any chest pain. Our third case is the 48 years gentleman who was also a smoker, 20 years, presented with the inferior wall STEMI for the rescue PCI into our center nearly a week after he had a STEMI and not thrombolized. On arrival at our hospital, he got a sustained ventricular tachycardia, and we do the defib 2 times with 200 joule. And after that, there's the SC elevation with US in 2-3 AVF with reciprocal SC depression and well AVN and V1 to V6. Echo showed the reduced AVEF with the posterior and inferior wall hypokinesia with moderate mitral regurgitation and tricuspid regurgitation. This is his ECG at the VT and after defib. So this is his angiogram. Left coronary angiogram is quite well with the mid-LED breaching. Again, there's a high thrombus burden with the total occlusion in the RCA. That is, first we pass the wire and there's a no flow at the distal. So we use the Sprinaligen 2 20 millimeter non-compliant balloon and still has just some stain or the contrast only. At the time, we just remind that routine trauma aspiration is not recommended in the guideline. However, there is a last residual thrombus pattern after opening the vessel with a guide wire or balloon. Thrombus aspiration may be considered. So in this case, we already crossed the wire and also the dilated with the true balloon, but still we don't have enough flow. Maybe the thrombus might organize because of the delay and transfer it to us. So we do the thrombus star 2 times, and after that we dilated again with the 2.5 20 millimeter balloon. Here we can see the quite good fluid after thrombus aspiration. Here's we got the red thrombus. After that, we deploy the 3.5 40 millimeter DES and mid RCA, overlapping with the 4.0 28 millimeter DES at the proximal portion. Here we can still see in the thrombus. After that, we done the DES self-stand balloon to the both proximal and the distal stand. So here is the final angiogram. He was also given the inoxaparin for 5 days, and he is stable and discharged. So in our cases, first case, we just use the GPI infusions and SC inoxaparin. And second case, we do the primary PCI with the OCA LED standing and followed by the subcutaneous inoxaparin injection. And third case, we do the aspiration thrombotomy standing and the SC inoxaparin. So, thank you very much.